Thank you so much, Ahmed. Thanks for the invitation. So today I will present a couple of cases that will really highlight the importance of physiology assessment for coronary artery disease. And I really hope that these two cases will make you question what you do day in, day out in the cath lab. If we have time, I'll go through the epidemiology, pathophysiology, diagnosis, treatment, and so on. So the first case is a 60-year-old female patient, otherwise healthy, referred to our cath lab because of sudden onset recurrent episodes of severe chest pain, each time lasting for around 10 to 15 minutes, were happening on and off over the last 2 weeks. She had a stress test which was abnormal, and hence she was referred to have the cath. So we did the cath, and as you can see, on injecting the right coronary artery, there was initially some mild disease proximally. We gave nitro, it disappeared, so we did not pay much attention to it. So we went to the left side, and essentially it looked completely normal. So then the questions that should come to your mind at that point in time, like, was this just a catheter-induced spasm? It means nothing. What is the diagnosis? Would you just say normal cath, this is not cardiac, think about something else, this is psychiatric, orthopedic, so on? Was this just a false positive stress test? So I think one key fact to highlight is when you don't give your patient a diagnosis, then they really suffer, because then they start going from one physician to the other, trying to find an explanation for why are they having this pain that keeps coming and really destroying their quality of life. So I think it's very important in such cases to actually go to the next step and do the physiology assessment and give your patient the right diagnosis so you can initiate the right therapy. So in this patient, we did then the microvascular assessment based on coroventus, which is essentially based on flow with injection of normal saline 3 times before and then 3 times after adenosine, and then it will measure for you the CFR, the flow, which is essentially how much is the heart able to improve the flow with maximal hyperemia, as well as IMR, which will reflect the resistance. So in her case, both were normal. CFR was normal at 5.2, IMR was normal at 18. So we moved to the next step and then did the acetylcholine assessment, and this was the baseline ECG. And the moment we gave her acetylcholine, she started to have exactly the same chest pain that she was having on and off for a while, and at the same time, on the ECG, we started seeing ST elevation. So we did the cath, and we found at that point in time she was having severe spasm in all of the epicardial arteries, and the moment we gave her nitro, all of that resolved. Her symptoms went away, and she told us, now I'm feeling back to my normal. So we then went to adjusting her medical therapy, got her on calcium channel blockers, specifically diltiazem, which really works well for such cases, and isosorbate mononitrate, and then her symptoms completely resolved, and now I'm seeing her 3 years later with no recurrence of the pain at all. The second case that will also highlight the other part of the spectrum here was this patient that we are dealing with, taking care of him in our clinic, 53-year-old male patient with CCS 3 to 4 angina, past medical history of diabetes mellitus, hypertension, dyslipidemia, had PCIs multiple times in an outside hospital, 2016, 2017, most recently had CABG in 2022. ECG shows normal sinus rhythm, echo normal ejection fraction, was already on good medical therapy by the time he came to see us on DAPT, statin, BCSK9 inhibitor, beta blocker, valsartan, empagliflozin, and nitro. LDL, as you can see, was very well controlled at 0.71, lipoprotein A elevated, which is an indicator of the genetic component to explain why he's having the symptoms he's having. So we did for him the cath, and essentially the right coronary artery had stents all the way to the PDA that were all patent. The CIRC had a stent that had some disease at the distal edge into OM1. The LAD had disease in the mid part just before the anastomosis with the lima, and the lima itself was patent. And the graft to OM1 was patent. So now the question is, why is this patient still having angina? Why is this patient having CCS 3 to 4 angina. So we did, in his case, the microvascular physiological assessment, and contrast this with the first patient I just presented. So when we put the wire here down the LAD, the FFR was normal at 0.91 because we knew there was no obstructive lesion in the proximal LAD. But then when we did the physiology assessment with CFR, IMR, as you can see, CFR was very abnormal at 1.8, and the resistance was very high at 41, indicating that his issue now is not epicardial disease, is actually in the microvessels, is a microvascular structural disease that he has. We tried him on ranolazine, which usually actually works very well for such cases, but in his case, he could not tolerate it because of side effects, mainly GI side effects. So then we did for him the coronary sinus reducer device, and a few weeks later, because it takes few weeks actually for the coronary sinus reducer to work, his symptoms improved in a dramatic way, and currently he is CCS2 angina. So I hope these two cases really highlight for you the importance of assessing physiology, because if you labeled in both cases no obstructive disease, send them home, they were going to still suffer from chest pain, and then probably went to psychiatry, orthopedic, GI, and went in endless loops of different opinions without actually having an answer. But once you give them the answer, then you can guide the therapy based on that. So quick slides about the epidemiology and pathophysiology. Angina, as you are all aware, is very common. But in 50% of the patients coming to the cath lab, when you do the cath, you don't find any obstructive disease. We call it ANUCA. Up to 60% of such patients, actually, when you do the study for a spasm, you will find that they are having spasm of the coronary arteries causing their symptoms. Up to 50%, they have a microvascular structural disease. I think one important piece of statistic to highlight here is even the patients you find in their case a significant lesion in the coronary artery and you end up doing stenting, at 1 year mark, up to 20 to 40% of such patients still have significant angina, did not improve. Sometimes it can be related to stent-related factors, whether it is ISR, edge dissection, and so on. But many times it's actually related to other causes of angina, mainly spasm and microvascular disease. And now that we have an invasive program that we do this day in, day out, we realize that many of these patients actually, when they had the stent first time, it was not actually broadly indicated, and that made the spasm worse, and hence their angina was worse afterward. The pathophysiology really needs its own session by itself to talk about, but for coronary spasm, there are theories about hormonal changes causing this, magnesium deficiency causing this, but there are certainly clear triggers that are well established, especially emotional triggers, cold weather, sometimes sympathomimetic agents that are in cough drugs. But one important thing to remember is beta blocker is actually harmful for these patients, because if anything, it will make them more prone to keep having spasm. And the moment you take them off beta blocker, put them on a calcium channel blocker, they improve. Coronary microvascular dysfunction essentially highlights the disease that affects the microvessels that we cannot see when we do a left heart cath, because when we do a left heart cath, we only see the epicardial arteries, so we cannot really assess the microvessels of the branches. And these microvessels can be affected by similar things that affect the epicardial arteries, but we yet cannot see it when we do the cath. How we make the diagnosis? As I highlighted in the first case, for spasm, it is mostly intracoronary acetylcholine challenge. This is the main way to do it. For coronary microvascular dysfunction, up to today, there is no technique to allow you to directly visualize flow in the coronary arteries, and hence we rely sometimes on non-invasive testing. PET scan is the one that is mostly studied, but you really need an operator who's well trained to read PET scan to assess microvascular disease. And for us, it is IMR, CFR with the Coroventus system. CORE-MICA study showed that when you actually, so what they did, they randomized patients with ANUCA to cath-based treatment versus actually doing the spasm study and microvascular. And they found when you give the patient the accurate diagnosis, start accurate therapy, they actually feel much better when it comes to angina and quality of life. So now the ESC guidelines gave it a class 1B recommendation to use it and to assist such patients with ANUCA and INOCA. Finally, before I finish, regarding therapy, as I highlighted, when it comes to microvascular angina, is mostly statin and so on to control cholesterol. Beta blockers, nebivolol is preferred in such cases. ACE inhibitors, ranolazine. But for angina, it is calcium channel blocker nitrates. And nicorandil is a very helpful one to use specifically for such patients. Coronary sinus reducer, as I mentioned, we mainly use it for patients with microvascular disease, and that's about it. Thank you so much.